And let's get to meet my guest for this morning as we begin to look at the issues that we have to discuss for you. So we will look at the new renewed restrictions, whether they are sufficient, particularly at a time when our cases are rising and not coming down. I'll be dealing with Professor Alex Dodu, who is Director General, Ghana Standards Authority. He's been Director, African Collaborating Center for Pharmacovigilance and Surveillance, and former Chairman, Global Vaccine Safety Initiative of the WHO. We'll have Dr. Samuel Kojo Amoakohene, an anesthesiologist, a COVID-19 ICU team leader, and ECHN Health Network Connecticut co-founder and president of Global Partnerships Halodine LLC. Also, Dr. Jesse Palater, ophthalmologist, investigator, and principal investigator for several clinical trials, co-founder and president of Halodine. Kwame Sapong-Asiedu, pharmacist and fellow, Ghana Center for Democratic Development, CDD. And later, dealing with the elections matter, we will be joined by Yao Opong, who is lawyer, senior lecturer, Ghana School of Law, and member Akufo-Addo's legal team. Dr. Dominic Ayine, MP, and also speaks for the John Mahama legal team, will join us. Martin Pebu is a rights activist and private legal practitioner. We also have Oliver Mausi Baka Vomao, who is researcher, Corpus Christi College, University of Cambridge, a chief technical advisor, University of Ghana School of Law's Democratic Vigilance Projects. So it's a packed show. We begin with dealing with the issues of COVID-19. And my guests joining us via Zoom, thank you all very much for making the time to join us.
Thank you for having us.
Great.
Thanks for having us, lawyer.
Right. So let me begin with Dr. Amoakohene, Dr. Samuel Kojo Amoakohene. Where you are in Connecticut, how are you dealing with the virus? I understand that you come into contact with people and you're actually a team leader, you know, for the purposes of this, you know, fighting this virus. How exactly are you dealing with it?
Once again, thanks for having us, Samson. I think the way we've been dealing with the virus here in the U.S. and specifically in Connecticut has been quite different. And specifically how, so when one gets sick right now, as we speak, as when one comes out, any kind of common cold symptoms, which is what most people will come to go to see their doctor or complain about, the first thing you do is you go get a test. Once you get a test, and you can get a test at a CVS or like a local pharmacy. So once you get that test and the test says that you're positive, then the first goal is that you isolate. You isolate meaning you go into your house, and in the US it's quite different. So you can have like what one can put together as condominiums like we have back home, but you're basically isolating in your room, or like if you have a 3-level house, you take the 3rd floor and you stay there by yourself, away from your family. So you leave food on the door, at the door, and just so you sort of stay away from everyone and stop the spread because of the effect on you or your family. So that's how people are doing it in a hospital. Once you coming into the hospital, every patient has their own room. So we isolate you, we pay close attention to you. Those who need oxygen supplementation, mostly when they end up in the hospital, it's pretty moderate or severe. So at that point, you monitor them and treating them as such in terms of being able to support them hemodynamically. and as you wait and treat these patients and hopefully get them back home. That's how we've been doing it here in Connecticut. As far as other ways of ensuring that people do not sort of go away from the norm of isolation, if you get COVID-19, you are not punished for not going to work. I mean, it's encouraged that you do let your job know so that you can be kept at home. And so every incentive is being given by the leadership to ensure that people do follow the protocol and that people do isolate, because it's a critical piece of how we fight this virus. If you're not able to isolate and you're gonna get sick and go out, then the risk of spreading the virus becomes really concerning, because as you know, at this point, the new mutations or strains that have come, they're more contagious in spite of whatever protective gear you may have on, more contagious and more deadly.
Right.
And so that's how we've been sort of handling it here in Connecticut.
I know that you have been following what is going on here in Ghana back home. What do you say about how we are dealing with it?
I think as a Ghanaian, as a medical doctor here, sometimes my heart aches. It aches because when I look at my people back home, it aches on so many levels, right? I'm sitting here in America, where, Dr. Pelletier and I were talking about earlier, when people come into the hospital, it's like checking into a hotel. You have your own room, you pick up your phone, they bring you food, you get all the services you need. There's nothing like you don't have oxygen or we don't have beds, except when the pandemic was at its peak in different parts of the country. But generally, you get everything you need when you get sick, when one is sick. We learned that most people with COVID-19 early on will go on dialysis, meaning that their kidneys will shut down. And we had every tool to just dialyze them, basically take all the filtration, the functions of the kidney away from their struggling body or healing body and do that for them. So I asked myself, how are we going to be able to handle these complications? Because we know coronavirus affects so many organs in our body. It affects your lungs, it tears your lungs apart. That's why people need oxygen supplementation, sometimes even go on a mechanical ventilator. It destroys your blood vessels, right? That's why people form the blood clots already to a lung that is struggling. It causes heart injury. That's why people's heart will be beating out of rhythm. Your liver will shut down. And so many other things. Your GI system, you're not even able to eat, bleeding into your stomach. And so when you compare that to what we have here and what's going on back home, it's a bit disheartening. I thought we did pretty well early on, but the second wave, or for lack of a better word, the third wave right now, I think we still have ways to go in terms of being able to get a handle on how people are getting tested, how people are getting sort of isolated, and how people are being followed and stopping the spread.
Now,
I mean, it's kind of sad that you see people going into big enclosed areas and don't even want to wear the mask. It's just not, we have to do a better job.
Right. Now, Dr. Makwina, I'll come back to you to ask, earlier when it started, you and I had some interaction about how to be able to improve our ability to use the oxygen, as in the
mechanical ventilator, and using the ventilator for multiple people.
Yeah, the ventilator, how to be able to use even just one for as many people as possible. And I'll come to ask you what you can suggest to help this country, because presently we know our ICUs are full. Now, Dr. Jesse Pelletier, what do you make of the circumstances that we find ourselves in now, and yet children have to go to school and buses are still allowed to load full capacity?
Yes, sure. Thank you again for having me on. And just, speaking from a perspective in the United States, we're looking at a totality of deaths that's just staggering. We're at, almost 460,000 deaths. Fortunately, this wave has been very difficult for the country. It's been a house on fire, but we're starting to come down a little bit now. And hospitalizations have decreased from a total of about 132,000 to about 90,000. But we're in a very difficult position because we just, we're waiting for the immunity to come on engendered by the vaccine. But at the same time, we're understanding that these new variants are circulating in the United States, especially in my hometown in Florida as well, the variant B117, and wondering what this is going to do to cases over the next 6 to 8 weeks. And we're also, of course, concerned what's going to happen down the line later in the year as the fall and the bad weather comes again after the summer. So, we only have the measures available to us right now that include our masks, our social distancing, our hand washing. Therapeutics have been very poorly developed during this entire pandemic, as we can all speak to. There's very little that's available. Might include things that are available inside the hospital, like remdesivir or like dexamethasone or immunoglobulins as well. So this is a real problem, and it's put a lot of reliance on the vaccine. So really, we have a race between the variants and the vaccines here in the United States that's stacking up. With respect to schools, some of the better news has been that transmission is less likely, and we've seen that through multiple studies in the United States, in Europe, and abroad, where transmission in schools tends to be less or at the same rate of that which is found in the community. So that's important. I think that children can probably safely be in school as long as those protective measures are taken, where they're allowed to wear masks, and if you can, do your best to maintain some social distancing. So I think that that's one thing we'll learn when we look back and do the postmortem on this whole pandemic, that schools should try to remain open while we may need to close other parts of the economy or the state, depending on where the caseload is currently at this time.
Right. And I'll return to you shortly, so we begin the discussion on the attitude to suggestions of potential prevention, medicines, or if you like, protocols, including hydrogen peroxide. And the Ghana Medical Association has issued a statement cautioning everybody about that. At the moment, the Food and Drugs Authority makes us understand that hydrogen peroxide is short on the market. So we'll find out how we don't seem to accommodate what may be good. Kwame Sapong-Asiedu, so in the last week, after the president renewed the restrictions, I have followed you on your social media page, and you have been very, very sad about developments, particularly significant people, quote unquote, that are losing their lives. What are we doing wrong still?
Well, thank you, Samson. And before I start, thank you for having me, and thank you to all the panelists who've joined. But I need to say a very special thank you to Professor Alex Dodu. A lot of people wouldn't know that my journey to become a biomedical scientist was actually started by Professor Alex Dodu. He actually wrote my reference to get me into graduate school for me to do a study in the University of Portsmouth and to be doing what I'm doing today. He always argues with me why I don't use all my credentials. But that's another argument we have in the background. But he has done a lot for me in life. I mean, he held my hands, took me to see John Smart and other things, and everything else is history. So I need to say a big thank you to him. Sometimes you need to acknowledge people who've been very instrumental in who you are today publicly. And when I was told I was going to come on the program with him today, I felt this was the most appropriate time to say, thank you, Alexo. I doff my hat to you.
Thank you, Prof.
Back to your question. Samson. I chose to pay this tribute to Alex because another person who at that time was with me and who is a colleague of myself and Alex lost his battle with COVID yesterday, Professor George Suminkufuor, who I started primary school with, I was in pharmacy school with. We all went into graduate school, and then we appointed lecturers at the Kwame Nkrumah University of Science and Technology together, me to pharmaceutical chemistry and him to pharmacology. Unfortunately, he's not made it. And I have asked myself, this is someone who is a professor below the age of 60. Professorial positions, like Alex will tell you, have about 2 decades at that age to give to society, by virtue of experience, by virtue of knowledge transfer, by virtue of research. And unfortunately, you lose someone like that at his prime. Life cuts short. And I ask myself, can we afford this? Is it something that as a country we can afford? And yes, globally, my colleagues in the United States will tell you that they have lost some significant people as well to this pandemic. But at least they have a much deeper and richer human resource than we have in the country. I mean, to replace a professor of pharmacology would take us at least 15 years, especially so when his other colleague who was with him, who was Alex's colleague, Professor Dakobi, also passed away about less than a year ago under these same circumstances, him not directly to COVID, but under the same circumstances when it started. So I'm looking at it, and then I'm going back, and then I'm looking at all these people who are passing, directors of companies, chief operating officers, and I'm asking myself, do we realize that we are going to end up possibly, after this pandemic is over, bequeathing to the next generation a society where knowledge and human resources has been badly hurt and damaged, and that we are going to end up having to train some people in certain categories from the scratch. And that breaks my heart, because I ask myself, could we have avoided this? And sometimes, much as I know it's a pandemic, I cannot help but say, yes, we could. There are some of them that we could have avoided. Yes, some we would have lost some, but because some of the things I cannot put public, if you hear the circumstances under which certain people pass, sometimes simple medications cannot be found. Ventilators, like you rightly said, are not available. It breaks my heart, because sometimes you hear of the medication that couldn't be found, and I ask myself, I can find this at a flash in the environment where I practice. And why should someone be passing away because they couldn't find safe? Even some of them with the money to buy it. And so that is what has been driving me this whole week. And it's really dampened my whole approach to this COVID fight, because it just doesn't add up. The level of human resource we're losing, we may not be losing large numbers like it's happening in the UK or in the United States, but we are losing a lot of quality, and that should bother us.
All right. So there are people who are concerned that the renewed restrictions has not affected, for example, getting on the bus. So they are still loading to capacity, and some of them are not really following the protocols, and there's a difficulty actually enforcing.
Yes, Samson, that concerns me as well, because like has been said earlier on the program, the new variants we are getting, especially the Kent one, and there's a California one that has come on board, there's the South African one, there's the Brazilian one, are 50 to 70 times more contagious, which technically means unchecked, you have actually changed the reproductive number, that is the ability of that virus to spread. So if people are going into buses and they are loaded, and there's no social distances, and every interaction gives an opportunity for people to be infected, and the infectivity of the pathogen has gone up by it's about 1.5 to 1.7, then yes, I sincerely worry, because more people are going to get infected. And apart from the fact that there's data coming out that the new variants sometimes can be more lethal as well, the other problem is we have fixed assets. That's the number of beds we have to treat COVID, the number of ventilators we have, the number of hospitals we have, and the more our caseload goes up, the more these will be chock-a-block, and that should be concerning us. So we need to actually start disaggregating the crowds, making sure that enforcement works, people are wearing their masks and other things. And like I've said so many times, at the moment, we are in self-preservation mode. We need to be responsible for our own actions. Much as we may have local constraints, like you don't have a 3-floor apartment where you can isolate and other things, we need to realize that we need to do a lot more. We need to learn to improvise. We need to make the best with the conditions we find ourselves in. Because if we don't, and these interactions continue, the infection rates will go up, the number of infected will go up, the number of people who will be in critical care will go up, and sadly, the public health domino effect means the number of mortalities we'll get will also go up, and we cannot afford that. Right.
Now, last week you issued a caution about, the hydrogen peroxide debate. How do you feel about what the Ghana Medical Association did in the statement that it issued, cautioning Ghanaians and, practically saying people should not use it for COVID prevention because it is not approved either by any of the regulatory bodies for the purpose?
Yeah, I mean, I agree with most of that statement, and I did raise that caution here last week. I did say that though you find, and the Ghana Medical Association actually acknowledged that if you look, you find data and research that points to hydrogen peroxide being used in different aspects of COVID management. But the science hasn't crystallized yet to a point where a definitive statement can be made whether it has any advantages or doesn't have any advantages. Having said that, I, as a pharmaceutical chemist, has also said that I'm concerned about even people's ability to serially dilute hydrogen peroxide, because you have the, what you call the 6% and the 9% on the market. And if you don't know how to dilute it appropriately to get the 1%, it's a corrosive agent, and you might end up bruising your mouth, your nose, and all that. So there needs to be a lot of caution. That said, I have also said that because there is some science out there, there's nothing wrong with us looking at this from a scientific perspective to see, because if you look at in vitro and in vivo studies, it's been shown that it inhibits coronaviruses in petri dishes in the lab. I mean, that is not disputed. But we all know as scientists that it's a one ball game, what happens in the lab, and another ball game, what happens when you try it on human subjects. So until the body of data on human subjects is clear, we need to be very, very cautious. But nobody is going to get that clarity unless us, our own scientists, decide to look into this and take, the leap with it and see, is there any substance here? A lot of times, science starts from anecdotal evidence, and then people pick it and research. So we need to do that as well.
Right. Maybe I start, Professor Alex Dodu, on this subject. And I have been forced to read all sorts of stuff. Some I don't understand. I try to get an explanation. And I've read the danger in not being careful about hydrogen peroxide. What do you have to say? And then tell us what you see about our general attitude to helping preserve life. Eja Adams sends me a message and he says, we still have crowded offices. The president said we should look at, running shifts. We still have crowded offices with air conditioning. Are we expecting the president to bring policemen to enforce the directive? And then some staff who speak against this behavior are rather those who are subjected to verbal abuse.
Great. Thank you very much, Samson. And I think D-Body Kwame Sapon-Asiedu, I think I just ought to say thanks to him because I've trained too many students, but few have made me blush. And he made me blush on air, but you didn't see that blushing. Samson, I'm going to take the hydrogen peroxide issue, especially in the discussions in Ghana, in the context which is based on both facts and science to educate the public. Sometime last year, the British Medical Journal wrote an article asking about what types of alternative issues can we look for COVID. That was May. So Professor Aite and a few eminent professors from Ghana wrote an article saying that hydrogen peroxide could be considered. And that was like a rejoinder to the article. And that was a very, very mature article. Fast forward to that article was in July 2020. Come January 2021, the article or the discussions has been that, okay, 8 people did not get COVID compared to another sample of 62. They were all health workers. Now, we don't mean to get there. You see, 1, hydrogen peroxide is a disinfectant. We all know that. 2, up to 1.2% can be used to disinfect surfaces or used as a mouthwash. That is known, that is proven. Now, in relation to hydrogen peroxide, for its usage in the treatment of COVID, we do not have solid scientific evidence. And the observational study given is useful. But from a regulatory point of view, we always say that we should be careful that in an attempt to get relief to society, the harms are not too much. Indeed, throughout any pandemic or any disease, what we are doing is to balance the benefits against any risks. The moment the benefit-risk ratio becomes unbalanced based on the society's needs, then that intervention should be stopped. Currently, as we have it, hydrogen peroxide has not been evaluated. It holds a potential, but it must be tested. Of course, the challenge always is this. When eminent professors come up with an observation, sometimes the eminence is taken as evidence, and then society goes into all sorts. But I think, like Kwame said, let us carry out a detailed, blinded study using what we all know how to test things, and then come up with a version on it, a view on it, which is based on facts. Without that, we'll harm our society, even though the intention from all parties is to save. And this issue is not new in Ghana. Indeed, way back in the early 2000s, we had someone saying that goat serum cures HIV. And most of us were roasted by saying that no matter the evidence you have, it must be evaluated independently, unbiasedly, and scientifically. So hydrogen peroxide, yes, mouthwash 1.2%, has been shown to be a disinfectant or a deodorizer for the mouth. However, it does come with some amount of risk, and the advice is that in relation to its use for the treatment of COVID, the answer is no. It's a very good antiseptic. It can be used by dentists and others who know how to mix it and use it. But for the general community, a lot of guidance is needed. And yes, in this pandemic, anything which can offer a solution should be evaluated properly. So here we are charging Ghanaian scientists. Carry out properly evaluated studies under the watch of the Food and Drugs Authority, because they will give the license as to whether it's good or bad.
I've read, seen and looked at some two medical articles that suggest that the demonstrated activity against SARS-CoV-2, if you're using hydrogen peroxide, there is no demonstrated, activity against SARS-CoV-2. And he also talks about being toxic to mucosa.
Yep. In fact, there was even initially a discussion as to whether it can have some potential to cause cancer. That is why we always say that the fact that an acid will kill a virus in the test tube doesn't make it a medicine. Because by the time you formulate it, you use it. And in its usage, you are saying, is it useful under all conditions? In the population which is largely not educated. If you are going to recommend any product, ideally the product should be ready to use. Because asking anyone to mix hydrogen peroxide, if it's the 6%, is 1:5. If it's the 3%, is 1:3, 2.5. Shall we say it's tricky? So the good intentions can be carried out badly. And the product is only good when the eventual user derives the expected benefits.
Okay.
So for most people, I would urge serious caution. I would say let's evaluate the studies. And if they are available and it is indeed useful, our expectations is that these are things you purchase in the pharmacy for use over 3 or 4 days, because then you have a ready mixed solution to be used as needed, so that you don't have to fidget with it.
So earlier I'll come back to the other aspect of our general attitude to helping, as in were the measures put in by the state. So that let's canvass this issue first. I was speaking to some doctors, and my surprise is that I've spoken to, at least you are the third person I've spoken to on this platform, people with expertise, immense expertise, who urge caution and say, let's try and do further studies. But I've also been dealing with some surgeons who are like, can we just stay away from it for now? Because we cannot, be assured of a number of things. What do you think about this? What would be a comment about this? Let me get from the two of you, from Dr. Kojamu Akohene and Jesse Pelletier.
Sure. Thank you very much. Yeah. Science, as we alluded to, is really a self-corrective search for the truth. And in that search for the truth, we also have to use our common sense as well. I actually took an investigation of this. I published some months ago in the Journal of the American Medical Association. And we did an investigation of the actual virus of SARS-CoV-2. We did that in a biosafety level 3 laboratory under very rigid conditions in conjunction with Utah State University. And we tested 3 things. We tested our formulation, the halidine formulation of povidone iodine. We tested hydrogen peroxide, and we tested the gold standard for antiseptics or alcohols, ethanol. And what we found is that the povidone iodine formulation killed the actual virus that causes COVID-19, killed 99.9% of it in 15 seconds or less. The ethanol was about 30 seconds, and the hydrogen peroxide had actually very little evidence of functioning at all with reduction to reducing viral titers. So that's one thing. And like we said, though, this is in vitro data and needs to be, further studies should perhaps be performed, but the basics are there and we've tested against this virus. So it's not the same to test particularly against other coronaviruses because SARS-CoV-2 is distinctly different. Moreover, as some of the guests alluded to, hydrogen peroxide can be toxic to the cells of the mouth, the gingival cells, cells of the oral and buccal mucosa. And it may even be mutagenic, which is of further concern. But when we're really talking about treating SARS-CoV-2 and COVID-19, we also have to consider the nose in the mouth, because the nose is really the initial dominant site of infection in all cases. And if you're to use hydrogen peroxide in the nose, it's also been shown to reduce significantly something called mucociliary clearance. This is the clearance or the natural beating of cells with fine cilia or hairs that beat unidirectionally to move debris out of the mouth and into the nasopharynx where it can be swallowed and deactivated. If you decrease or depress this function, whatever enters your nose has more contact time with epithelial cells. And if that is SARS-CoV-2, you're more likely to have an established infection. So I think we have to be very careful with using hydrogen peroxide in this setting.
Dr. Kujamu Akuhine, let's hear what you have to say about that. And he, as Jesse speaks, he makes a comparison with the providine iodine. And we made contact to you guys because we understood that you are doing some work and have done some work with providine iodine in comparison with hydrogen peroxide. And you are dealing with that product, halidine. Right, so tell us what you have to say about the debates on the hydrogen peroxide.
I think your guests have spoken really well. Professor Dodu has demonstrated, yes, he's got the title for a reason. Well spoken, and Asiedu as well. So from where I sit as an anesthesiologist, I witnessed too many people die, and I still see it, unfortunately. I think my heart was aching when Asiedu was speaking. And he made a perfect analysis. We cannot afford to do things like people in the West do. Like I said, the white people do. And it's simply because they have the capacity and the power that we don't have. That's why we have to think outside the box. When you talk about hydrogen peroxide, and I think it's well spoken, but I'll go a step further and say that I would not recommend it. And here's why, Samson. Laura, it's important to demonstrate that our immune system, one of the first defense for immune system is our respiratory system. Coronavirus dominantly infects your nose, eyes, oral pharynx, and it touches your lungs and it burns it up. I've seen too many CAT scans of patients whose lungs have been shot. So when you talk about putting a medicine, a product like hydrogen peroxide, which has many useful effects, but not for this case. Because when you're taking a product that has been known to be sometimes even cause cancer, and you're putting that in the nose, that is going to destroy your first defense of mechanism fighting anything. Talk about in a pandemic that has not been seen since 1918. It worries me, it bothers me. I think we cannot afford to lose too many more lives, especially for people like us back home in Africa. So that's why early on when I assembled my team, I said, hey guys, we have a product here. Povidone iodine has been in use for over 50 plus years. We've done this before. We know we can do this. Let's put this together again. We knew that the science behind the use of povidone iodine was far enormous, and that we can definitely put this together and help to save lives. So what we did is basically do the work, do the research, and what we were able to come up with, be able to formulate a product called Halodyne, which is basically a povidone iodine-based product. Because povidone iodine, as it's sold on the market, has other excipients or components to it, which limits the ability to be able to put it in the nose, which means you cannot just go and buy it and mix it, because then you begin to form other components, iodophores, or different forms of iodine, which necessarily may not be good or may be toxic, like we talked about hydrogen peroxide. So we formulated Halodyne to be safe, effective for the nose and the mouth. And I end on this, lawyer, that a study came out of France that was published in JAMA called the Killer Study. And another large paper came out of Asia that demonstrated and proved our point. It took the work we'd done in the lab and proved the point in actual patients. And the one that came out of France that was published this Friday, it demonstrated that patients that use povidone iodine, basically Halodyne, by day 3, they cleared all their viral titers. By day 3. It was about 2 times higher than the control group that did not use anything, the ones that were told to go home, isolate, hope to get better. When you take that and you could talk about the paper that came out of Asia, they actually had a bigger study, started about 1,000 patients who had just been diagnosed with COVID-19. They whittled it down to about 300 people in each group. And I'll tell you 3 things they found. Mortality, the number of people that died from using povidone iodine versus the ones that did not do anything. In a 303 in each group, about 5.6% of the people who did not do or use povidone iodine or Halodyne-based product died, which is about 18 out of 300 people. And only 1.8 patients out of the group that used Halodyne died. That you talk about impressive difference with a known safety, known efficacy, and almost no side effect. It had no side effect on your thyroid as well, which the French study demonstrated. When you talk about the number of people that cleared their viral load by day 7, only about 2.6% in the group that used povidone iodine only tested positive, which means you're talking about roughly 98, 97% of the group that used povidone iodine by day 7 had cleared all their viral load. Coronavirus, just so we know, can stay in one's body for up to 3 weeks. So if you're getting sick and clearing the virus by day 7 using povidone iodine Halodyne-based product, that's very significant. And you compare that to the group that did not use anything, the control group, which about 70% of them still had positive. And the crux of the matter is how many of our loved ones, like I said, are dying and we're losing. I mean, I've heard about the stories back home. For the sake of time, I can't repeat them. It pains my heart. For the group that did not use any povidone iodine-based product,
we know.
You talk about 20% of them were in the hospital, in the ICU, ventilated, their life changes, right? Versus only about 3% in the group that used povidone iodine.
Right, Dr. Mwakwuhine, we know that COVID has thrown the scientific community into a whole lot of quick stuff, and also to try and try stuff. It is the reason that, like Jesse mentions, remdesivir, is that what you call it? Yes, that's what was used for Trump, right?
Correct.
And that was effective.
Part of the thing. They used a different cocktail, but that was one of the medicines.
Right, but until then, we didn't know that it could be that effective. So
correct.
Why should we look at, should we have so much disbelief for what Professor and co are projecting instead of for the povidone iodine? Okay, so once I get into all of this myself, I just check with the doctors, and I've had some doctors say they would rather prefer that if I wanted to use anything, I should use the povidone iodine rather than the hydrogen peroxide. But my thinking is the povidone iodine is also already made and in the market. Why the skepticism or the caution over hydrogen peroxide against as in favor of what do you call it, iodine, povidone iodine?
Okay, so it's important to understand something like Professor Dodo and Asiedu said, and Dr. Pelletier said. Safety is key. You can do anything in the lab, but safety is key. So, lawyer, you cannot put medicines into your body that may be causing cancer with the belief that it's going to work when we know the data does not support this specific virus, SARS-CoV-2 virus. It's not there yet. Hydrogen peroxide has not been shown to be effective against SARS-CoV-2 virus, and you can look into the data, it's there. So that's a fact. And then you take it to a different level, the toxicity level, specifically when you look into the nose. The fact that it's going to destroy your natural body's defense in the nostrils, in the nasopharynx, in a situation where you actually need those defenses to be able to, your noses to be able to humidify the air, sort of purify it, warm it up, remove particles, viruses like coronavirus. You do not want to be, you want to buff those mucosa up. You want to buff those cells up, right? You don't want to destroy them. So I think the point is that hydrogen peroxide, I will stay away from it for the reason that my panelists have already alluded to, and for the fact that I've already mentioned. Now, povidone iodine or halodyne, for the purposes of discussion, is it's a drug that is known to those of us in the medical community. Samson, lawyer, povidone iodine-based product is what we use to treat chronic sinus infections. Patients who have chronic sinus infections, their nose, they get infected all the time, chronic headaches. We use similar product to treat. So we have been using it to treat patients, other medical diseases. We know it's safe, we know it works. The work we did was to prove that indeed we can use it to kill coronavirus, which is what we're able to prove. So when you talk about halodyne, it's an engineered drug out of povidone iodine that does not have any alcohol-based substance to it, right? So it's already made, it's already engineered so that it's safe for the nose and the mouth for repeated use. Does not affect your thyroid. It's different from the one you buy in the market or in the hospitals, because those are commercially made povidone iodine, and it has quite a bit of excipients or additives to it. When you mix those ones at home, like to Professor Dodo's point, when you buy chemicals that you can use for many different reasons, you buy from this pharmacy and you bring it home and you mix it, and it's not done by a pharmacist, it begins to form different compounds within it. And at that point, what you bought to be povidone iodine has now formed different combinations of different molecules and will not be as effective, just like we're talking about hydrogen peroxide. Right. So that's why halodyne was what has become the way forward. And I do believe that in places like in Ghana, like we're working with the Nigerians, in South Africa, this is one of the ways to fight this new mutation. We're losing too many lives until Trump got sick and got this new treatment, which I'm not sure even if I were to get sick again, I will get it. Nobody knew of that product, right? And so now that we have the clinical data, now that we've known about this product for a long time, but can actually substantiate it with clinical data, I think that's the way we fight this virus.
Yeah, I'll return. We'll talk about vaccine, and I understand all of you have vaccinated. Kwame, you just vaccinated last week, is it? Kwame, hello, Kwame.
Yes, I did last week. Yes.
Great. Is there any other comment you like to make about what we just spoke about? And more particularly, is there something you would like the Ghana Medical Association, together with the state, to be looking at, rather than simply say, stay off?
You see, I would make a basic definition that as pharmaceutical chemists we use to differentiate between a drug and a poison. And it's a simple definition. A drug is a poison at low concentration, and a poison is a drug at high concentration. The reason why we say that is every drug inappropriately used can kill you. And every poison sufficiently diluted can be made safe, because every medicine has what we call the therapeutic window. So that is where we are dwelling at the moment. I can hear Dr. Mwakohene say clearly, povidone iodine has been used. And yes, if you go into any pharmacy in England, you can even find it. It has been converted into a drug, even though iodine is known to suppress the thyroid gland, but at the concentration, it's been converted into a drug. What I'm saying, and based on the Ghana Medical Association letter, is that currently, if the body of evidence for hydrogen peroxide is weak, like Dr. Mwakohene said, it's not there yet, and Prof. Ayite is giving anecdotes that it could be there, rather than let the general public use it inappropriately as a poison, rather than use it appropriately as a drug, why doesn't the medical fraternity, the pharmaceutical fraternity, take it on board, look into it, and then have an outcome? Just last week, there was a herbal product from cryptolepin that was licensed for clinical studies. If you ask Alexo, when I was a student of pharmacy, long before me, Cryptolepis sanigulenta, which is the plant from which it comes, had been researched for malaria for ages by professors that preceded Alex, by people who did their PhDs that preceded me. My own colleague, Dr. Adaichome, did his PhD on Cryptolepis. Today, it's being used and repurposed to see if it can work in against SARS-CoV-2. That is how science works. So if we want to find out if hydrogen peroxide can work as well, we can go down that route as well.
Okay.
That is different from what Dr. Mwakohene has said, because he's actually quoted scientific data and says that this is the result. And so some of us can go and review the data. We can go and look for systematic reviews. We can look for Cochrane reviews to see if the body of science is there. And if it's there, then what he's saying is not in dispute. Likewise, that can be done for hydrogen peroxide. There's no qualms about it. But as it stands now, I see it more in the realm of a poison than of a drug.
Okay. Thank you very much. Now, if we may talk about the expectations that we have. People have a lot of expectation, especially after listening to you this week, that we are getting the vaccine. But begin with our behavior and our attitude, whether we are helping or we are hurting the fight.
Okay, I will take the attitude, Samson, but if I may just have one word just to support my three previous speakers on hydrogen peroxide. Samson, I want to position here that the state, the Republic of Ghana, has a role in all these discussions. We pay our taxes so that the state will provide us the protection we need, whether police or things. When it comes to the use of medicinal products, the Food and Drugs Authority is the regulator. Regulation means using science and law to protect societies. Medicines or medical products are common good products that humanity needs. But the Republic has to balance between making it available in ways that can damage society and using it. So if we have a product, let us subject it to the rigors of independent assessment by our regulator. When, it's very difficult when very highly respected and very well acclaimed seniors come on there and speak, the public believes. And they have a right to speak because they guide society. However, we must always balance between giving an observation on what should be tried and letting the language come out as if it has been approved by our national regulator, which in this case is the Food and Drugs Authority. Right. Now, shifting to the way we have managed COVID. My first point I would say is that we should not let the Ghana Health Service become the COVID Health Service. We should not let that happen. Have we managed COVID well or have we not managed it well? I love what Dr. Mwakohene said. If you're in America, you are told to self-isolate. I come from Jamestown. I go to Jamestown a lot. This is a house. It's just a front door. There's nothing inside. How do you self-isolate? So in our current management, we are trying to achieve a balance between several competing and necessary interests. More than half of the people around Jamestown will not have toilets in their houses. So yes, we lock them down. How are they going to attend to nature's call? Something they must do. So there are all these things that any policymaker or government has to balance. But all within that, I believe that there is progress. The first hope I have, in fact, the first excitement I have is actually listening to the Ghanaians on this panel. Some say we've come a long way, but as a country, we have the best players in the world, I keep saying, but quite often organizing them as a team. As we speak, Ghanaian researchers in Baltimore did mention about products that can be used to suppress COVID. We've heard the two Ghanaian experts. What is needed is let's put them into a team and let us deliver solutions to Ghana. But I will tackle some of the issues pragmatically. His Excellency the President made two statements.
The thing about putting Ghanaians from wherever together to help. I've heard doctors say people are self-medicating. They have some symptom, they are not too eager to go to the hospital because we were told earlier that don't come until you are ill. And they want to be sure that whatever, and they are taking self-medicating. There are people who even have gas in their homes, you know, and all of that, you know, happening, and it is hurting. We have heard about claims about the neem tree that we've all knew, the leaves that I have done a lot of that at a point because you feel exposed. And then we are told this may not be too good, it can rather hurt you. So you have to look for the respected, you know, practitioners who are telling us, oh, what is it, hydrogen or that. So I had to take my time to weigh what was good. So when I feel exposed, what I have done has been, okay, the doctors say the Provident iodine is safer, and it's already made for that. You could use it very safely, so I do that. But still, I have questions. So if you say we should bring them together, how?
For starters, I mean, clearly the scientific or healthcare community owes a lot more to Ghana than we are delivering at this time of pandemic. Way back in March 2020, I raised this question, that how do you manage COVID in the time of malaria? Because they have symptoms which are similar, fever, loss of taste, etc., etc. Throw in January Harmattan, when we tend to have breathing problems, and there is an issue. The public has a right to be anxious. I mean, it's a pandemic. They have a right to ask questions, any question, but we have a right to explain to them in the way they would understand. We've heard idea calls on ivermectin and this. A few factual points. Responsible self-medication is not a bad thing. There are medicines that you can use on your own with knowledge. Once it's responsible, it's okay. However, trying treatments, you know, based on social media and this has a huge potential to damage you. To avoid that, it's up to we, the healthcare community, we, the scientific community, to be going out regularly to have a vaccine against these bad news. And that vaccine is proper news, which will inundate and move out the bad news. The public has a right to know. Seriously, I've said it. I am an appointee of government, but I believe that healthcare workers everywhere should go out there with the right information. If they do not know, then they have failed us. Because the public is looking for simple, clear, unambiguous information. Currently, people are anxious because they get too many stories from too many different places.
So do you know, for example, specific what I asked, do you know, for example, if we are reaching out to Prof. Saite and his team, Dr. Mwakohene, Jesse, and the rest, the things they are talking about, which we know is already out there on the market, and people are using them anyway?
I have called the scientific communities and told them that, look, go out there and speak the truth. The issue is that hydrogen peroxide has not been approved for the current indications. You should not use it as such, or else the risk to your body is a lot. Any product you use should have been one approved for the purpose you are using it. The fact that you can buy it in the pharmacy doesn't mean that you can use it different from what is written on the label. So we always make a difference between a chemical and the products, because even the labeling is part of the products. We always say that without the labeling, the instructions, it's just a chemical. So you need to know how to use it and how to use it well. Okay. I believe that, I almost said fellow Ghanaians, I believe that Ghanaians have a right to a lot of information. One, we are living in the time of malaria, COVID, upper respiratory tract infections. you are going to get cold, you are going to get other things. If you can reach out to a pharmacy and do the RDT for malaria, at least it rules out one option, because all diagnosis is differential. 2, please do not use the words of just Alex Dodo or anybody. Let's use verified information. And the first source is the product registered. Because if the product is recommended as such by the Food and Drugs Authority, then the state is liable for any problems if you use it as intended. Number 2, we are living in a country where practically a lot of things cannot be done. But I think we need to think different. I heard about shifts and overcrowding. Something, what prevents us from thinking differently and stretching the workday to 16 hours? Because 1, we need to work, because our economy is so informal that people cannot be furloughed, they stay at home and they get money. Most workplaces are doing 8 to 5, crowding the streets and crowding the workplaces. Is there space to extend that workday from 6 a.m. to 10 p.m. with 2 different shifts? I mean, that is a possibility. Can we consider in the formal workplaces 6 days instead of 5 days? I believe that there are several options that we need to begin to look at. However, as His Excellency the President says, there are a lot of local products that can be used to mitigate some of the symptoms of COVID. You have mentioned neem tree. Inhalation has been a strategy we have used throughout history. If you do it correctly, even if it doesn't cure COVID, it helps. It relieves your nose, it relieves your throat. In fact, sometimes just decent steam inhalation with or without any essential oils comes in very, very, very handy. Now, I know Ghana is beginning to put together a team to look at search for vaccines. And it beats my heart because way back in the early 2000s, we raised these issues. I'm sure you do know the challenges we had during the Ebola times when I raised the issue that if we do not begin to look for vaccines now, when the next big pandemic hits, we'll be caught out. And we have been caught out. Now that we've reached here, what are we going to do by way of solutions? I believe that we have so much indigenous science that can help us. I believe that we have so many products that we can repurpose to give hope and guidance. Yes, we are looking for a vaccine. But even then, these are vaccines that we did not take part in the development. And something I would like to take time to explain to readers, when the coronavirus problem came about, the US government voted $10 billion to look for vaccines, diagnostics, and therapeutics. You want to be able to diagnose the disease. You want to be able to treat it and possibly use vaccines to prevent it. $10 billion in the program called Operation Warp Speed. Warp came from the Star Trek movie, moving faster than the speed of light. The US government did say that we are doing this knowing very well that because we are moving fast, a lot of the products will not be useful or safe, but we will get a product months earlier than another product. Number 2, they set a clear criteria that products should be able to reduce disease severity by at least 50%. The third thing they did was, once there's a candidate vaccine, they would start developing approaches to produce it, even if it will not work as a vaccine. So these are well-considered issues. As we speak, the US government has spent $12.4 billion. Now they have results to show. There are vaccines already being rolled out. Yes, we need some of that vaccine, and hopefully, as His Excellency says, we will get some. But these are the dimensions. Just yesterday in Israel, the Achovi Medical Center in Tel Aviv came out with a product. It's called Exo CD24. Of 23 people giving the product, 24 people giving the product, 23 recovered fully. If you're going to do science, you say it's 97% effective or 96%. But we are not saying it's not a cure yet. It's only phase 1. Will the same results play out when they give it to 1,000 people? Would there be risk that we have not seen? So yes, we are getting excitement with a few products, but we have carefully evaluated them. We would not know the burden of harm that we associated with the use of these products. And we saw it during the Ebola times. A lot of the interventions appear to have cured Ebola, but later people are living with long-term complications, which is a burden not just to them, but to society. In the current debate, my take is this: as healthcare workers, we must intensify our education to Ghanaians. The education should be simple and direct, and we must be able to communicate uncertainty, because there's so much we do not know about COVID. There's short COVID and long COVID. Short ones are those who get it either with no symptoms or they tend to recover. Long COVID, as we are now calling it, are those with long-term sequelae, and that is worrying. Why is it that those who appear to be overweight or obese tend to succumb faster than those who are slim? We just do not know. Unfortunately, we have been terrible at communicating uncertainty because society expects us to be little gods. So we don't want to say that, yes, we know, no intervention will work all the time for everybody. None. I've been in this business for years.
I'll return to you to finish up on the question of vaccine and our approach and attitude, because there's a lot of, information going out there, and people, don't seem to want to trust the process yet. But we are hoping to receive them for the purpose. Kwame, this hope of vaccine, how much hope is there really? You have done yours. There are those who say, look, we are hearing all sorts of stories about the vaccine, so we should find our own means, rather local means, rather than waiting for a vaccine.
Thank you, Samson. I think Alexo has, by and large, done justice to a lot around the vaccine story and how we've gotten to this point with vaccines. I mean, he's spoken about the United States approach. And the US, yes, has got results to show for vaccines, for treatments like what was given to Donald Trump and stuff like that. If you look at the UK experience as well, which is one I'm very conversant with, yes, they also put £1 billion just into vaccine research and gambled on their universities, Oxford, Imperial College, Southampton, and also went into the United States, for example, with Novavax and invested in it. They went into France with Valneva and invested in it. They put a lot of money into ensuring that their end game, which was herd immunity, because right from the start, that was what the UK argued, that there needed to be some form of herd immunity, was achieved. The wild route, they quickly discovered that wasn't an option because just too many people were dying. At that point in time, people didn't really understand how to manage the disease properly, and the hospitals were getting overwhelmed and other things. Now we have the vaccines. The problem with blacks, not just in Africa, even in the UK, even in the United States, even in Germany, is that disproportionately, we do not like partaking in clinical trials of any form. It is very difficult to convince a black person, whether it's a black American, whether it's a, what do you call it, a Ghanaian, a Nigerian, a West Indian, to undertake clinical trials. And rightly so. There have been a lot of scars with people of black origin engaging in vaccine or other medicinal trials. I mean, you can go back to the Second World War, you can go back to the 60s in the United States, you can go back to aspects in Europe, thalidomide and all that. There are so many stories that scare people. But, like Prof. Dodu said, you get to a point where you ask yourself, as science evolves, checks and balances are put in place to ensure that historical antecedents and wrongdoing do not happen in the future. We are in a pandemic and we're looking for vaccines. Everyone to a fault accepts that the route out of this would be a preventative vaccine of a sort, because we cannot continue perpetually living our lives social distancing, wearing face masks, and even destroying our sociocultural behaviors, because that also has psychiatric and psychological impact. And one of the burdens that everyone is scared to speak about is the psychiatric impact of this pandemic once we found a way of getting out of it, because there will be some post-traumatic stress disorder for health professionals, for patients, and all that. So the answer is that the quicker we get out of this, with less damage to all of us, to economies, to individuals, to professionals, like the lives we're losing, the better. And the only way we're going to do that is through vaccination. Unfortunately, What has happened with a lot of these anti-vaxxers is they look at the vaccination data and they're like, oh, only 9% of blacks or ethnic minorities were involved, whereas there was 80-something% of whites or Caucasians and all that. And they're like, it's not been tried a lot in blacks. The question is, the vaccine developers set out not to try this in blacks? The answer is no. They put it out for volunteers to come. Disproportionately, the ethnic minorities opted out. The vaccines are here now, and still you have people making negative noises about it in a way that might lead to, even if vaccines arrive in Africa and in places like Ghana, less people taking it, so the herd immunity threshold is not reached. And if that is not reached, then the protection for the community at large is much, much lower.
All right.
What I keep telling people is that there will be implications there as well, because our economy cannot also open up properly if that happens.
All right.
So we cannot have these conversations, Samson, and say, yes, I know. But like Alex says, I'll end it here. It is up to us as health professionals, as scientists, to take these conversations like we are having on your program to the general public and confront these anti-vaxxers with scientific evidence, bear facts, and debate them openly so that society can benefit from it.
Right. Kwame, my very final question to you, and for a quick response, is we are being told that the more contagious UK strain is dominating Ghana's current COVID-19 transmission. The question Ghanaians are seeking answer to is, how did that happen? People were coming into the country for Christmas and the rest of them, and we were paying $150 for the antigen test. We made them go home to isolate. Is that what happened? And is that the reason we are where we are? What can we do?
Quick one, Samson. When it comes to viruses and their mutations, yes, it's possible that some came in from travel. But if anything to go by what the data that's come out of UK, especially Surrey in the last 3 days, there are viruses in the UK that have mutated to mimic the South African vaccine with no travel history. The point about viruses is they mutate for one reason and one reason only: one, to become more contagious, and one, to become the predominant surviving species. So it could even be that some mutations have happened in Ghana, but because we haven't been sequencing at large, we don't know. And we are trying to blame the influx from other countries. If you look at a country like the UK, which contributes about 50% to the genome sequencing database, they have so many mutants coming in this country with no travel history. So the travel history might be a red herring based on what we are seeing with the mutation of this virus. But the most important thing is we have the most surviving species currently hitting us, and we need to act appropriately to minimize contagion and minimize the number of infections we get out of it. Otherwise, our health system would suffer.
Okay. Thank you very much, Kwame Sapong-Asiedu, for making the time once again for us, as always. Thank you so very much. Now, Jesse and Dr. Mwakohene, briefly, starting with you, Jesse, what should be our attitude towards vaccine expected?
Yeah, well, I think it's really important in that the idea of a vaccination and the rise of variants is very important, because the vaccines, even though they've been shown to be perhaps less effective and less neutralizing in certain situations, they're still very helpful in moderate to severe COVID. So no matter what happens with the rise of variants, having a really sound bedrock of vaccination strategy is going to be vitally important to developing immunity within the population. And unfortunately, we're just going to continue to see these variants. As has been alluded to, this is the nature of these single-stranded RNA viruses. They're going to continue to look to become more fit. And as that happens, we'll have to evolve along with the virus. But again, the bedrock and the foundation is going to be the distribution of vaccines. Right. In the United States, as was alluded to before, we had that Operation Warp Speed. And this is an incredible public-private partnership that helped fund the mRNA vaccines and some other vaccine platforms as well. But we really struggled in that last mile. So once the safety efficacy was done and studied, we started to have trouble with the administration. And we're improving, but with a population of 330 million, we're going to need at least 150 million vaccinations, or 125, to start to get some community immunity, and hopefully that issue will be less in a more concentrated population like Ghana.
Thank you very much, Dr. Jesse Palater, for making the time to also join us. Dr. Amoakohene, I had asked that you may share with us what may be beneficial to us about the ventilators. Now that our ICUs are full, how do we get ventilators for multiple, to be used by multiple people?
So early on during the pandemic, one of the ways we were looking at, because our ICUs were also full, and there was no way you were going to be able to get ICU beds or new ventilators. So one of the things that we all looked into was, as an anesthesiologist, I'm always putting patients to sleep, waking them up, sending them to their loved ones. And coming up with looking at the physiology and seeing how we can use one ventilator to ventilate at least one or two people, as opposed to having one ventilator for one patient. And that was sort of talked about in the US, and that was one of the ways we resorted to, that if push came to shove, that was how we're gonna try to give patients or family or loved ones the chance to survive this virus. Because as healthcare providers, as doctors, our goal is to always get patients back to their loved ones. And I don't look at patients and turn them away. I give them a chance to survive. And so that certainly can be done in Ghana as well. Where if that is the case, as I'm learning from you right now, I'd love to help out with the government and sort of see how we can work together and show them and really be able to help with the ICUs being full. I think the last point I'll make is the fact that we have to be very vigilant in Ghana, because we don't have the healthcare system that we have in the US. And so we have to take these government measures, and to Professor Dodu's point, and Sidu's point, take every measure we can to ensure that patients can get the care they need and our loved ones can survive this.
Thank you very much. Dr. Samuel Kojo Amoakohene is an anesthesiologist, a COVID-19 ICU team leader, and co-founder and president of the Global Partnerships Halodyne LLC. Dr. Jesse Palater is ophthalmologist, principal investigator for several clinical trials, and co-founder and president of Halodyne. Kwame Saponesiedu, pharmacist and fellow, Ghana Center for Democratic Development, CDD. Now, Dr. Alex Dodu, we understand that the people's expectations may be cut short, because when we get the vaccine, it's not everybody that is going to get it.
The initial plan is that we are expecting about 20 million doses of vaccine by the end of March. The first doses will come. I know for a fact from several other sources, including the COVAX source, that Ghana has been allocated the AstraZeneca vaccine, the one being manufactured from the Serum Institute of India. Now, Dr. Amoakohene touched on something, that when the vaccines come, there are two things. He said, will we have enough? I think the fundamental question is, how prepared are the population to receive the vaccine? I served as a member of the Global Advisory Committee on Vaccine Safety. This was in the early 2000s. So I've done vaccine safety. Will I take a COVID vaccine? My answer is yes. There has been so many conspiracy theories, but just to allay the fears of our listeners and viewers, yellow fever vaccination for international travel has been mandatory for years, and we take it without even thinking about it. So why is COVID different? Thanks to vaccination, we have all but we've eradicated smallpox, removed polio from Ghana, measles is gone, and so on and so forth. But during the Ebola time, two things came about. People were afraid of using vaccines. So I was part of the Vaccine Confidence Project. How do you give confidence to people? Because once there's a pandemic, people rush to be protected. But as the disease goes away, then they become slow and they don't want to take it. Ghana will have we will not have only one vaccine, we'll have multiple vaccines. The expectation is that the AstraZeneca Serum Institute of India one should be here by the end of March or thereabouts. In preparation for it, there was selection. Now there has to be procurement. But at the same time, there should be communication. Communication to get the public ready, not just for the vaccine, but to also expect that the protection offered by the vaccine goes with some amount of risk. There will be side effects. There will be. I mean, it's not going to be 100% safe. It never happens. So we need to communicate that there will be a lot of benefits, but there will be an accompanying measurable amount of tolerable risk, which the population should be ready for. Then we need to deploy it. Deploying vaccines may sound like a small issue, but just imagine the 238 districts of Ghana, ensuring that every vaccine is kept at the temperature it should be kept, and given to people who are then followed up to be sure that they are not damaged.
Okay.
Because at the end of the day, safety becomes key. In the US, they are using FedEx to move vaccines around. They are using pharmacies to deploy vaccines. In Ghana, it will be the usual system we have been using for EPI, the Expanded Program on Immunization. But we cannot rule out the possibility that churches and mosques could be used as vaccination centers if enough people...
I understand that the actual number we are looking to receive is 19.5 million doses by the end of June.
Yes.
But who are the category in the population who will not be vaccinated?
Normally, for starters, children will not be included. They are more protected and they are not passing on the vaccines. Those with allergies, those with underlying conditions, those whose immune system appears compromised would also not be vaccinated. Then you come to who should be vaccinated first. Usually frontline health workers.
Pregnant women will be vaccinated?
No, because even though there is no information that the vaccine is harmful to pregnancy, there's no information that they are safe in pregnancy. And we always say that the evidence of absence is not absence of evidence.
Okay.
We don't know that they work, but we don't know that they don't work. So you spare them. And then you leave those with HIV/AIDS, those who are on cancer treatment, the very, very old who are frail. These will all be ruled out. However, doctors will be told that based on your individual patient, you may recommend that a pregnant woman who has asthma and severe disease and who is at risk, you've got to look at her as an individual and judge from the potential benefit and the harm that you know can also happen and make a call. And sometimes there's no science to that call. Okay.
Thank you so very much, Dr. Dodo, for making the time. We understand that the leadership of the Catholic Church Global, that's Caritas Confederation, they have also issued a statement and they are actually asking for what they call the right to vaccine for all. And they are linking that to a campaign for debt cancellation because of the times that we are in, particularly for the benefit of Africa. Because if it has to do with money, we definitely can't afford it. All right. Thank you so very much indeed. Professor Alex Dodo is Director General, Ghana Standards Authority, Director, African Collaborating Center for Pharmacovigilance and Surveillance, and former Chairman, Global Vaccine Safety Initiative, the World Health Organization, 2012 to 2016. We couldn't have had any one better to help us in this. Thank you so much.
Thank you.
We take a quick break. When we return, we go to the Supreme Court.